from ASAMI, India. We are having our second episode of Budding Elizarov Surgeons, Telangana start. So it's going very good. Thanks to everybody, and request all the other states to participate actively in this. So without wasting any time, I request our coordinator, Akansha, to start the webinar. Thank you. Thanks, Akansha.
Good evening, sir. Good evening to everybody. Thank you so much for joining in. So we are here with our second webinar from the state of Telangana, and we are going to be covering basic topics by my professor Ravindranath sir, under whom I have done my senior residency, and followed by which case discussions. So, sir, should we begin, or like, can I give a brief intro of Ravindranath sir? Shamshul sir?
You should introduce first. Please introduce the faculty.
Yes, sir. Yes, sir. I'll just share my screen, sir, and I'll just introduce Ravindranath sir. Sir, is my screen visible?
Yes. Yes. Please go full screen.
Yeah. Yes, sir. So Ravindranath sir is actually right now the professor and head of the department of ESI Medical College and Hospital at Sanat Nagar, which is under the central government of India, and this is in Hyderabad. So sir has done his MBBS from the prestigious Osmania Medical College and Hospital in Hyderabad, and he went on to do his MS Orthopaedics more than 3 decades ago from the same hospital. And after which he has worked for 3 decades at the same institute, going ahead from being an assistant professor to a professor across the 3 decades. And eventually he was posted in the government general and chest hospital, where he took care as the chief consultant for 9 years, and brought about major changes in the field of trauma, Ilizarov, and plastic surgery. So sir has been conducting Sunday classes for all masters and DNB students for the last 32 years at Gandhi Medical College, which is another state-run government college in Hyderabad. And after which sir has been the head of the department and of course the professor at ESI Medical College and Hospital Sanat Nagar for the last 5 years. And this is his 32nd year of experience in terms of teaching and bringing about students to become teachers. And sir has varied interests in mostly Ilizarov plastic surgery techniques, being majorly flaps. He's an innovator of many techniques, and along with IIT Hyderabad, sir has designed an entry guide handle for doing a PFN. And sir has made surgeries easier by going ahead and innovating more in terms of publishing whatever he has thought of and designed for tibial plateau fractures, and like I said, for PFNs. And he has also designed radiolucent bolsters for stabilization in the OT for making surgeries convenient and more effectively executed. So sir has more than 55 platform presentations in various regional and national seminars and conferences. Sir has more than 15 publications as a first author. And for the avian hip, sir has preserved the native hip by doing a Mayer's pedicle graft and has published that. So sir has a series of cases with more than 30 years of follow-up. And this was published in the International Journal of Orthopaedics and Traumatology. Sir is a guide for MS and DNB exam going students, and he's a consultant at Aster Prime in Hyderabad. So sir has been a chairperson for many conferences and workshops in Hyderabad and in Telangana state for Ilizarov and other trauma-based workshops. So sir has always been guiding us along. When I was doing my senior residency 2 years ago at ESI, this was a picture taken at that time. And these are some of the pictures which were taken when sir has always been guiding us and putting us forward, our ideas forward, taking in suggestions and pushing us to achieve greater heights. Other than that, sir has interests in photography, and sir does watercolors, paintings with watercolors. And sir has a lot to Sir has a lot of insights to give, even with the smallest of all doubts that we have had as students working under him. And I'm very happy that today Sir is going to be talking to us on a topic which is so dear to both of us, and that is Ilizarov. So, Sir, I'll stop sharing my screen. And I would like to right now welcome our Telangana Orthopaedic Surgeons Association President, Dr.Vijay Bhaskar, sir. Welcome, sir.
Yeah. Thank you. Thank you so much. Welcome all the members who joined this today's webinar. Please go ahead. Please go ahead.
Okay, sir. Thank you, sir.
Thanks, Kasha, for a wonderful introduction of Ravindranath, sir. That was a very good. We really thanks our senior faculty like Agarwal, sir, Manish Sawan, sir, beautifully joining here. Yeah.
I would like to welcome all the national faculty of ASAMI here. Thank you so much, sir, for taking some time out and joining for the webinar. Really means a lot to all of us.
So you can share your screen, sir, Ravindranath, sir.
Yeah, thank you, Dr. Akansha, for the introduction, though I may not be up to the expectations. The topic today that's allotted to me is very basic in Ilizarov fixation, targeting the budding Ilizarov. And bear with me and pardon me if I bore the senior people like Agarwal, Shamshul, Hoda, and others, please. Dr. Prasad. This is very basic and it may be a little boring to you all, maybe. So I'll start by sharing my screen here.
Yes, sir.
Good evening once again, all the young orthopedic surgeons who are interested in Ilizarov. The only advantage of Ilizarov is we can make the patient walk on a broken bone. So let us know the basic principles of this Ilizarov. The flow chart goes like this. Position of the limb is very crucial here. Safe zones, one should know very well about the safe zones. The types of the tips of the wires, when to use and where to use. And what are the reference wires, which I always try to find out very confusing to the youngsters. And what are the use of drop wires. And how do you stretch the skin while passing the wires. How to avoid the stiffness of the joint when you really exactly stretch the skin when passing the wires. And what are the trajectories of the pins, so that you can avoid oblique pins, obliquely trajected pins, and to avoid unstable fixation. And we assess the stability of the fracture. And once you get the stability, you should know the loading effect on the fracture through the pin. Once you know how to stabilize the fracture, you should know the amount of rigidity in relation to limb to the ring. That's very crucial here. And what is important is the clotted post and the use of the hemispherical washer. And a few tips about the translation and working length and the use of hinges and twisted plates and the motor. This is the flow chart I usually follow for basic principles of the Ilizarov. Before that, the position of the part is very crucial. We always use some bolster in the form of folded drape or kidney trays wrapped in a drape again, and then some wooden blocks. I used to start with the wooden blocks, a concave surface of wooden blocks to accommodate the lower part of the thigh and the ankle joint, and then sandbags are commonly used. But the problem with them is all of them are very hard and all of them are really dense. We really can't see the wires going when we are supported by these blocks. So I got an idea how to use these blocks, which are very lightweight, and then they are not deforming. Suppose you take a towel, folded towel, over a period of time, it gets deformed. A circular pillow will become a flat one. and then it's radiolucent. That's one big advantage of these bolsters, that you can see clearly on a C-arm. The image is as good as you are not doing, and nothing is there between the limb and the beam. And they're easily prepared, designed and prepared, and then you can make them in any forms. So these are the bolsters which are used to keep the limb stable, so that our hands are free, and we can play with the rings and wires. This is the profile view of the limb with bolsters beneath the knee joint and bolster beneath the heel. Both of them are radiolucent. You can easily take the C-arm images clearly without any problem. And this is the frontal view from above. And this position of the limb is very crucial. Once you get a good positioning of the limb, it's easier to pass the framework of the Ilizarov. Then comes the safe zones, the basic principles of Ilizarov. Somebody puts a question, what is the basic principle of the Ilizarov? I always say it's a controlled distraction osteogenesis. It's always controlled, but it's not exact osteogenesis. It's the histiogenesis, because you're stretching the skin and then rest of the soft tissues around the bone. So it's a histiogenesis, a control. You can say distraction or compression of histiogenesis. Then why is in Ilizarov? There's a crucial question to be answered. They maintain the bone fragments. Akansha, how can I take out the template on the right side?
Which template?
The template. I am able to see all these. Okay, I can minimize them. Okay, right.
You can just go to view, sir, and then you can click on hide self view if you would like, sir.
I can hide it now, right?
Yes, sir.
So to maintain the bone fragments in position, and to maintain the bone rigidity of the fragments again in position, and the wires are helpful or meant to keep the hop pins or full pins away from the soft tissues, so that you get good amount of what you call telescoping effect of the soft tissues through the wires which are fixed to the rings. The advantage of wires is that it will destroy very little bone and bone marrow. If you tension them, it decreases the vibration, increases the elasticity, and prevents the soft tissue damage along with the bone destruction. So once you remove them, there is a little bone or soft tissue defect or destruction. So that's a big advantage of wires over the shank pins. So let's talk about safe zone. In the upper third of the leg, I am just confining myself to the upper third of the leg component only this time. In the upper third of the leg, you have the cross-sectional view. You have the bones, tibia and fibula, and the anterolateral compartment is very little there in the upper third. And you have the medial as well as distal gastrocnemius muscles or heads of the gastrocnemius, and you have the vessels. And then common peroneal nerve is very crucial here. You can pass the wires almost obliquely, intersecting each other about 45 to 60 degrees also. And the wire on the right side is called reference wire. When I say reference wire, the wire should be parallel to the joint line. That's very crucial. Unless you get that parallel to the joint line, the frame will not be parallel to each other in both in the anterior, posterior, and lateral views. So that we can avoid the neurovascular bundles in this position. We can also use the shank pin in case there is fracture upper 1/4, where we need to prevent the extension of the proximal fragment. That can be neutralized by putting a pin in the form of pin from the first ring or proximal most ring. In the anatomy, you can see that is the head of the fibula, and you can see the common peroneal nerve and the iliotibial band. So the safest way of putting the reference wire is through the head of the fibula, or you can go a little anterior to the head of the fibula or superior to the head of the fibula, but never behind the head of the fibula or neck of the fibula. You invariably damage the common peroneal nerve. This is very crucial when you are passing the first reference wire. And we go to at the level of tibial tuberosity. You have the bones there, fibula and tibia, and you have the anterolateral compartment well formed, and you have the posterior compartment, both superficial and deep, and you have the neurovascular structures, the anterolateral compartment as well as the posterior compartment. You can pass the wires in the same direction, either mediolaterally or in the transverse direction also, maintaining the angle between the two wires. Now we are very safe. We will not go and interfere with the neurovascular structures. You can also use again the pin, since it is the fracture. If the fracture is involving the upper third, the tibial patellar tendon tends to get this proximal more extension that can be neutralized by passing a pin anteriorly without crossing the posterior cortex. When you come down to middle third of the leg, you have again bones, and then a bigger anterolateral compartment as well as lateral compartment and the posterior compartment, and we have neurovascular structures there, and we can pass the wires in the same way without hindering the vascular supply or neurological supply of the limb. These are the safe zones for the middle third of the leg. When you go down to lower third, it's very easy to pass wires because there's not much musculature. And then we have the bones there again. Anterolateral compartment is very less here, only tendons are there. And you have the lateral compartment, and then both compartments of the posterior component and the neurovascular structures. You can pass the wires in this direction without damaging the neurovascular structures. So these are the safe zones for the leg, where we can get good stability of the fracture, of the containment of the fracture to the bones, and we will not damage the neurovascular structures. And a few tips about trocar tip, tips of the wires. We have only two types of tips available in orthopedics. One is a trocar tip. The other one is a bayonet tip. In the trocar tip, we have three facets, where when we drill them through the soft bone, there's nothing, you don't see any bone coming out when you're drilling with a K wire. So we call it as drill in. We don't take any bone, so it's called drill in. But when you go to the sort of harder bone, we need to use a bayonet tip. Bayonet tip has got, if you see them, there are two bevels in opposite direction. The bevels are there to cut the bone, and then we call it as a drill out of the bone. So we use them more harder bone. This is commonly used in the carpenters also, where they have the bevels to cut easily in a hard surface. I always use the pre-assembled frame. The advantage is that it's very less time is spent on this assembling. When patient is given during anesthesia, we can make an assembly of the frame, and it's easier to align the fragments in a straight frame than like I am trained in that way. I got used to that way. Again, this is the frame. The frame should be parallel to the long axis of the limb. There should not be any deviation. That can be achieved only by reference wires which are parallel to the joint surface, both at the knee joint as well as at the ankle joint. So we call them as reference wires there. Then we have some drop wires. When you don't want to use, or when you don't want to have more rings, or when there is no place for the rings, we can make use of the drop wires. Drop wires are generally used with a threaded rod or some sort of post, female post or male post, attached to the ring on either side of the limb, and then pass a wire that also acts as a stabilizer or supporting to the reduction rings. And you can also use the drop wires along with the olive wires, where we can maintain the fracture in the form of compression through the olive wire. Once you've done that, you should see that we should always, when the reference wires are well placed, parallel to the joint surface, we see the frame is parallel to the long axis of the limb, both frontal view as well as lateral view, as you can see in the radiograph here. So when passing the wires, you should always keep in mind how to bring down the damage to the soft tissues. Otherwise, we should maintain the physiological length of the muscle, so that we should have some maneuvers when you are going through the compartments through the muscle and reaching the bone. This will bring down the amount of joint stiffness when you stretch the joint soft tissues while passing the wires. Like in the case when you're going from anterior posterior, at the level of ankle joint, for example, you need to keep the ankle in as much equinus as possible without disturbing the direction of the fracture. and the wire goes out of the anterior compartment and entering into the posterior compartment, you should keep the limb in dorsiflexion. That means you have to stretch the limbs to maximum movement in the same direction to avoid the soft tissue contractures while passing the wires. If you're going from posterior to anterior, it's the reverse again. You can see that then so that you will bring down the amount of soft tissue stretch as well as the joint stiffness during the process of rehabilitation. So normally we tend to make multiple holes or multiple attempts into the cortex. That should be avoided because they're all stress risers when somebody wants to bear weight immediately post-operatively. So always better to use one stroke or to learn to put wire in one stroke flush with the ring. Sometimes you can use the wire fixation bolt and pass the wire, a cantilever wire fixation or a eccentric cantilever wire fixation bolt. Then you can pass the wire so that the wire is almost flushing with the both surfaces on either side. But if you make some angulation at the, like suppose you make a 5-degree angulation, it will go up to 15 degrees when it reaches out of the other cortex, where we need to go for a washer. So sometimes some nuts also need to be put, but the wire is not very strong when it is not perpendicular to the long axis of the bone. That is to be avoided. But it's always better to go through the bone and the marrow and outside the cortex. That means one should feel the two cortices, give way of the two cortices when you pass from one particular bone like tibia, near cortex and forecortex. It's better to avoid passing through the cortex. You will not have the feel of going through different cortices. The disadvantage is it acts as a stress riser, or we call it the breach in the cortex. And during the process, since it's a avascular structure, we may go in for a cortical osteomyelitis. Then we need to understand how to get a stable fixation. In this representation or animation, you can see that is the best for to get a horizontal wire, number one. And then we can get a 90 degrees. 90-90 is the best for stability. Since you cannot go 90-90, we have a compromised situation where we need to go in a oblique direction, maintaining the angle between 45 to 60. Given a choice, it is 60 that is more stable than the 40. Less than 45 or 30 is not going to help to get the stable fixation of the fragments. Some people, they try to use parallel wires thinking that they maintain stability. But the problem with that is there is toggling of the bone in horizontal direction because there is no angulation of the wires. So you tend to toggle mediolaterally. So that can be prevented in case you want to go for, you pass the wire obliquely with a 45 degrees angle between the two parallel wires. When you have 30 degrees of angulation between two wires, what happens is, suppose you have wires like this, we think it's very safe to pass the wires because you're not injured any vessels there. But the problem is, again, you have the toggling in the sagittal plane. That means anteroposterior toggling is there. That can be avoided either passing a horizontal wire, keeping those two wires in the position since they are not jeopardizing the vascularity or neurologically. But always better to have them in this direction to get a stable fixation. Can this toggling happen in the coronal plane? Yes, it can also happen in coronal plane when you do like this with less than 30 degrees of angulation between the two wires. You get a toggling
Hello.
of the wires. Hello?
Hello.
Sir, yes,
Hello.
sir.
Hello? Any, shall I pause now or?
Just 1 second.
Please
Sir.
continue, sir. Please continue, sir.
Yes.
Okay then. So there can be toggling of the bone fragments in the coronal plane. Again, that can be avoided when you just replace them in the required direction of the wires. Once you get a stable fixation at 60-60 or 50-50 angulation, you get a stable fixation and the load on the bone will be uniform or even, or even evenly concentrated load is there on the bone. But when the angle is less than required, that is around 30 degrees, you get a loading is not concentric, it's uneven, and then there's failure of the fixation. So you get an uneven loading on the fragments. People think that the longer the wires from the limb, is it allows more elasticity, more vertical migration, vertical compression. That is not the case. You should not have longer wires between the frame and the surface of the limb. It should be ideally 2 fingers breadth anteriorly, about 3 fingers breadth posteriorly, and 2 fingers breadth on either side. That means 2 fingers space between the ring and the surface of the bone, and then two wires in each fragment are the minimum requirement to get a stable fixation. So farther away from the limb to the ring is less rigid and it tends to fail easily, early also. And a few words about the slotted posts. They are very useful. They are meant to have some sort of what you call translation. Then we make use of the hemispherical washers, and that can be demonstrated here clearly. You can see the movement of the post by about 5 to 7 degrees in either direction. So that is helpful to get a phenomenon called puller or pusher when you want to move the fragment in any direction or whichever direction you want. That means you want to bring it down, you have to pull the fragment towards the ring. The basic requirement for that is you should have a pivot wire, only one wire horizontally or vertically, obliquely, whichever direction you want, preferably in the line of pull that acts as a pivot over which the bone gets movements to get required alignment. You can also use the same post to pull away with a pivot wire. It acts as a pusher. The threaded rod will act as the shank pin will act as a pusher, or threaded pins on the head towards head side will act as a pusher. That way you can get alignment easily. It is easily said in the theory, you can get easy translation unless it is a very acute case, but you can try to do the translation. We pass a wire like that with a stopper or then you can lift them to the required length or corresponding holes are maintained. So you want to bring the limb to that level of the ring hole, where we can tight on one side and then try to do tensioning on the other side. The limb moves or the bone moves sagittally. Once you get required sagittal movement, we can also go for a coronal movement also with the olive wire, where we take out we loosen the pin screws on the other side and try to tension it there on the opposite side. Then we get required amount of movement. Then we can tighten the previous side wire fixation bolt and then go for tensioning again. So we get translation in the both sagittal plane as well as coronal plane. It's easier to set on the PowerPoint, but very difficult to get on the table on a patient. So that is the movement in the coronal plane. This is very crucial. One should have a working length. The working length is very crucial for any plating of the long bones. Similarly, the working length is also very crucial in the Ilizarov frames also. That is the fracture line. And these are the second and third link that is imagined that way. But the ring is far away from the fracture. And the other ring is also very closer to the reduction ring. The number 2 is a reduction ring, and number 3 is a supporting ring. The distance between these two is much narrower than the distance on the right side figure, which has got good working length, where you can take good stability of the fragments. Or the supporting will stabilize the reducing ring easily when you have a good working length or a scientifically proved working length. A few words about the hinges. The placement of hinges we can have some other time, where to place the hinges and all. But you should know what are the hinges. They are nothing but female and male posts joined by a nut and bolt, and then applied to the rings, or 5/8 ring or the full ring. But you have hinge, but you should also have a sort of twisted plates wherein we can motor is attached to that without any disturbance in the plane of the rings. The rings are applied perpendicular to the bone, but rings are not mechanically 90 degrees to the limb. When they are obliquely placed in the mechanical axis, we need to have twisted plates with again washers, conical washers or hemispherical washers, where to get the motor exactly in the one direction only, where we can do the effect of the distraction or compression. In this case, we are trying to close the wedge on the lateral side. And then you can see the motor has acted and hinges become straight, and you get the good reduction of the fracture. At the same time, both rings are parallel to the bone as well as to the mechanical axis or the long axis of the limb. So that's the reason why we need to have twisted plates when you want to go for hinges and to apply motor for through the twisted plates. Best wishes to all youngsters. Thank you very much for the chance.
Thank you very much, sir. That was a very comprehensive lecture on the basics.
Yes, very basic.
Very much required for all the students who may be questioned in their PG exams and also senior residents who are working now and getting some training. Sir, there's a question from Praful, sir. He's asking how to connect oblique pins to the rings.
Yeah, that's what you can use. This is from Praful Herod. As I said, we have drop wires. We also have drop pins also. We can use the same male or female post, 3-hole or 4-hole, depending upon the span you want to go away from the frame or the ring. And you can use I generally use H-clamp clamps to fix the pins in oblique direction. Or you can use universal clamps also. Or you can use the same, like my company fellow will give the wire fixing bolts that can rotate in 360 degrees. And then you can put that so-called drop post. It can be a crancho cube or a male post or female post. And then you can pass the pin through the post into the bone. It's a drop pin. I was talking about drop wire. It's a drop pin.
I want to ask one question.
Yes, sir.
Yeah. It's a very nice presentation. I want to know, do you have your protocol? Yeah.
What? Protocol for?
Yeah. I want to know your protocol, where to use the wires or where you use the pins, or you have to, there are three modules: wires plus pins, only wires and pins. So what do you think from which place, what you do?
Generally, in a leg, in the tibia and fibula, I prefer to put all wires, unless, as I said, if the fracture is upper third at the level of tibial tuberosity. When you have pins alone, the power of the quadriceps mechanism is so high that it may sort of erode the wires. To prevent or to neutralize the action of the quadriceps mechanism, I use the pin there. Or when I find the passing of the pin wires is not safe, for example, in the let us say in upper limb, in the humerus, or in the thigh, in the femur, upper part of the femur, or middle half to upper part of femur, where we are not sure of passing the wires without geopartizing the vascular structures, I use pins there. But in the lower or tibia and leg regions, I always prefer to go for wires, multiple wires, stabilize the frame, and then mobilize the patient as early as possible.
Actually, when the hybrid frame came, so we thought we apply the wires plus screws. But then we realized that our certain cases in the tibia, they have gone into the non-union. Because if there are wires, you can do the compression till your wires form the bow-like upper and lower vertebra. Because then I came to know what are the causes of non-union. Because we give the compression and compression till the both upper and lower wires, they become the bow-like.
Yeah,
so this was not possible in the hybrid cases. So when the hybrid cases, we have done the hybrid cases, then our lot of cases had gone to non-union. So in the fracture cases, other things we have shifted to the wires. But in the lengthening, other things you can use some amount of sine spring. But my personal experience is in the fracture in the tibia, one should use only wires.
Yeah, that's what exactly. I do the same thing.
Yeah.
The advantage of wires is that it will allow the axial compression and distraction while somebody is putting weight. It's not a rigid fixation, but a stable fixation, allowing the axial compression of in the long axis of the bone. That's the advantage for the callus formation.
Yeah. I personally think if one are using wires, and giving the proper compression at the wires, then 100% we can say that our bones will unite, because a lot of problems in the patient which comes to us, they will apply the Ilizarov frame and the bone has not united.
Yes.
So then we came to know, until unless you don't give the compression
Yes.
and make the upper and lower limbs like bow, then we are sure that we should get the 100% of the union.
Yes, you're right, sir.
Yeah.
So there is a question from Dr. Dilip from Kerala. He's an assistant professor, sir. He's asking, in the slides for the safe zones, wires were passing through fibula in all the levels. Is that okay?
Yeah, that's what. If you really, the vessels, suppose you take the vessel in the posterior compartment, the vessels are not exactly lying on the interosseous membrane. Unless you, like you see in the forearm, the anterior-interosseous and posterior-interosseous, they lie exactly over the interosseous membrane. There is no muscle between those vessels as well as the interosseous membrane. But the leg, if you go down from middle third to lower third, there's a muscle supporting and protecting the vessels. You can try to go a little posterior to the fibula safely and then pass the wire. And in the demonstration, they're exactly going to the interosseous membrane because it's the animation. It's easier to do that way. But otherwise, you can go to the, you should have feel of going through first cortex, second cortex, third cortex, and fourth cortex. That's very crucial when you want to put a wire in that direction.
But I personally feel in the fibula, we put only at two places, upper end from the head of the fibula and lower fin from the just 2 to 4 to 5 centimeters above the lateral malleolus.
Yes, exactly.
In the middle, we don't need the fixed fibula.
Not necessary, not necessary.
Yeah. So there is no question of the vascularity distal.
Yeah.
Sir, about 30 people have joined us from Ortho TV Live. I think they are postgraduate students. And the question that one of them has asked is that whether to really use sham spins or to go for an all-wire frame, because according to whatever they have probably read from the Ilizarov is to go for an all-wire one. So that's the doubt they have, sir, to go for hybrid all wires.
Actually, in fact, it's easier to go in for hybrid wires, hybrid fixation, because passing pins is very easier than putting wires, avoiding the safe, going to safe zones. But as I said, as Dr. Agarwal said, I always prefer to go for all wires in leg component, because we need to have the vertical or axial compression when somebody puts weight on it. That's very crucial. With avoiding the mediolateral or anteroposterior translation, that's very crucial to get the compression at the fracture site. And if it's a comminuted fracture where the bones are not, we don't need to go in for a sort of compression and all. Even then, we can go for wires. We go for multiple rings, like more than 1 or 2 rings, and then do it with all wires. But of late, I've seen youngsters doing with pins. It's easier to put a pin, like you do it in an axial fixator, uniplanar or biplanar. It's easier to do a pin. But original Ilizarov is not about pins, it's about wires.
Yes, I agree with you.
Yes, sir.
Sir, Dr. Vidyasagar, Assistant Professor Orthopaedics from Osmania Medical College, has just asked a question. In the lower fourth tibia non-unions, how to get additional stability in the distal fragment apart from putting 3 wires, and how to attach, whether we should attach a foot plate or not, sir?
Yeah, we'll do that case next week, Vidyasagar. I know about that case you're talking. That fellow is not, the most important for any surgical procedure is the patient's complaint, whether you use plating or nailing or Ilizarov. Most of Ilizarov, it's a cumbersome procedure, but a fantastic procedure where the patient is mobilized immediately. When the patient is not complacent, I was told that he's referring to one patient we have done about 2 weeks ago. The patient is not complacent. That fellow started walking without any support, as if his bone is united. In that case, when there's comminution at the supramalleolar area, I always use a foot plate and then pass 2 wires, 2 oblique wires in the calcaneus, and one wire in the metatarsal or base of the metatarsal, and fix the frame with a semi-arch, semicircular arch or half ring to the parent frame, so that we can avoid the toggling of the fragments at the supramalleus area. Of that, I'm also trying to do passing a wire through the talus also. You just go in front of the lateral malleus, or you have to go from the middle malleus, just below the tip of the middle malleus, little anteriorly. You come out from the other side in front of the lateral malleus. So that you put a drop wire like thing, 2 posts for the semicircular or foot plate. That also will help to maintain the what you call the ankle alignment, as well as to maintain the which is a very supramallear, very comminuted supramallear fractures. But of late, we have done about, you must have seen many cases in ESIC, where we have done, we just also must have seen that we have passed many wires, the patient is not compliant, he'll start walking immediately. It will cut through because it's a cancellous bone and multiple pieces are there. Preferably add a foot plate to that, it will do the job.
Sir, can I ask a question? There was something that I had read in one of these books, sir, wherein the intraoperative assessment of instability at the level of the tibio-talar junction, if at all it is present, then we need to add a foot arch. Is that so, sir? Like, is that the method to go ahead and decide in any scenario?
That can be there in because we have done few cases of Charcot's ankle, where we are gone for a fusion of the tibio-talar junction. Most of the time I do transfibular orthodesis and then fixing with Ilizarov frame, wherein we need to get the mortise of the tibia, mortise of the talus exactly in alignment with the tibial plafond. In that case, I always go for a pin through the talus, because they always have instability. The talus goes into varus or it dislocates into varus or valgus. So we need to stabilize that. In addition to the wires going through the calcaneum, as well as, and then stabilize with the midfoot wires also.
Okay, sir. Thank you, sir. Sir, Dr. Karthik Reddy has asked a question. When the post-operatively patient complains of pain on dorsiflexion and plantar flexion through a wire that is passed from tibialis anterior, so this wire will pain so much and cause so much irritation, it causes much more discomfort than the entire Ilizarov fixator itself. So how to address this particular problem, sir?
That was what I was referring the soft tissue stretch. When you pass the wire, you should always stretch the structures which are nearer to the entry of the wire. When the joint comes to neutral position, the amount of stretch or the muscle or whatever soft tissue is not tagged to the wire. Once it is not tagged, there is smooth movement there, and then you will not have irritation. So somebody passes the wire without taking care of the movements of the neighboring joints while passing through the wire to the soft tissue before getting to the bone. You should always stretch them. It's very crucial. That point is very crucial. Suppose you could tend to go to the tendoachilles. That's terrible for the patient. You go to tendoachilles, he will not walk at all. It's very irritating and then painful to the patient. Similarly, tibialis anterior tendon. So how to avoid that? I always take the help of my finger, index finger, put it on the shin of the tibia, and the proximal phalanx, the distal phalanx length should be always taken into consideration. That much of bone you should go behind the or below or posterior to the shin of the tibia. So you are safe, will not go into tendons of the tibialis anterior. When you go to muscle, there's no problem. When you go to tendons only, there's a problem.
Right, sir. Sir, in the post-operative period, is there any role for detensioning of these wires so that these painful, irritable wires, so that the patient is relieved to some extent, sir? Or should we go ahead and replace it and redo it again all over?
But in my rather, I did not have the problem, but theoretically, suppose let us imagine a situation where the wire has gone to the anterior tibial now, let us say. You have tensioned it. When you tension it, there is always some translation, a few millimeters translation anteroposteriorly when you are tensioning it. So that causes irritation to the nerve. If the patient persistently complains of paresthesia in the distribution of the particular nerve area, we prefer to cut the wire, not detension it. it's preferred to cut the wire so that it will fall in place. The nerve will recover, and then do the procedure later on the next Saturday or next day or whatever it is.
Okay, sir. Sir, PG students from Osmania, they are asking, what is the exact amount of tension in newtons per meter that we need to do for metaphysis and diaphysis, sir, with a dynamometer?
Dr. Agarwal wants to answer.
Actually, I tell you, regarding the how much tension to be given by meter, it depends on the which age person you are. If you are doing the old man, your tension will be less. If you are doing the child, your tension will be less. If it's a very healthy man, for example, 18 to 25 years, the tension will be. It's basically what I feel. Tension depends on your hands, how much you push it. It depends on the quality of the bone. I tell you one story. Initially, some 3 surgeons from Russia, they stayed for me in our hospital for 6 months. So their Russian bones are very, very strong because they use a lot of non-veg meat and other things. And Indian bones are not so strong. So initially what happened, they have given a lot of tension. One day I found that the whole ward is crying of the pain. So then I realized that tension depends on the age, and Indian bones are not very strong. So we should give the tension according to no parameter is there, according to age, according to the quality of the bone. Because if you give more tension, there will be the cutting effect. And the people, I came to know that the cause of the pain in the Ilizarov is the more tension on the wires. So you should not give more tension. That's all.
Right, sir. Sir, Dr. Karthik Reddy has asked a question. In osteoporotic bones, sometimes there is translation of the whole ring in spite of adequate tensioning. So how do we address this, sir, during the follow-up or intraoperative?
It is not related to the tensioning of the wire. It is related to the angle at which the wires are intersecting.
Angle.
That is very crucial. So the intersection of the wires is more important than tensioning of the wires. Suppose sometimes, many of the times, I see that my tensioner is not working. I try to pass the wires and do some manual tightening. But it is the angulation of the wires with each other is very crucial than the tensioning that can be avoided when you want to have this, when there is the translation of our whole frame is moving the medial lateral or anteroposterior direction, mostly medial lateral only. So angulation of the wire is more important. The minimum is 45 degrees, maximum is 90 degrees, 60 degrees. There is no compromise there at all.
Yeah, I agree with you, because in the osteoporosis bone, one should have more angles.
Yes, exactly.
The angles are not given more than the normal bones. So the sliding of the rings takes place. So one should take care that in the osteoporosis bone, the angles should be maximum as you can do.
And just to add, sir, suppose in proximal tibia, if you cannot add 90 degrees angles, you can add olive wires or hydroxyapatite pins also. Osteoporotic bones.
Can you
So in osteoporotic bones, just like if you have a very osteoporotic bone and then we have to apply in proximal tibia, and we cannot apply 90-degree wires. So in that case, we can get use of olive wires,
yes.
Number 1, or sometimes we can use of hydroxyapatite strands also.
Yes. Okay.
So there is another question from one of the PG students. So they are asking whether there is any role for readjustment of this tensioning in the post-operative period when the patient comes for follow-up in a country like ours, where there is a chance that there probably could be loss of tension because of which the patient may be having pain. So
yeah, for that reason, normally we should not, if you are very sure that your tensioning is perfect and you tighten the nuts and bolts very perfectly, you can cut that wire, making a sort of U-shaped one. When you're not very sure, don't cut the wire, but only bend it. You just bend like a semicircular, with the adequate length that can accommodate into your dynamometer. In case of a post-operative, you find that the nuts have become loose, the bolts have become loose, then you can use the same wire and put the dynamometer in the ward itself and then start doing tensioning. Because you're not cutting the wire, you're not bending it, you're only, you're not what's called making 90 degrees angle, you're only making an arc-like thing. You can straighten it and then use the same dynamometer and then tension it again further and then tighten the nuts. The reason why, once you finish your surgery, you should always check all nuts and bolts are tight or not. Right from the adjustment of the fixation of the half rings, everything should be checked before, and then only patient is sent out of the theater.
What personally I feel, you put a finger on the wires.
Yes.
And the tone and the sound is produced there, that will show whether our wire is in tension or whether it's not tension. But the sound of the wire tells us the tension is there or not. That's
yes, sir. Yes, sir. Right, you are right.
So there is another question from Dr. Anup Maurya. He's asking that the olive wires do sink in, especially in the osteoporotic bones, especially in the metaphysis. So how do we address it?
Yeah, I have a sort of innovation. We have the washers for 4 mm, not the bigger washers. 4 mm will have 2 types of washers. 4 mm candidated screws will have 2 types of washers. One is smaller, just enough to accommodate the head of the screw. Those washers can be threaded onto the olive wire and then apply the same thing. So that will not rather the olive part of the wire will not go into the bone. It will prevent, the washer will prevent that way. You can also use bigger washer. That's more safer, but you need to cut the skin and then soft tissues to accommodate the washer. But that washer will not, it will not stop at the olive wire. It will go through the olive wire also. So better is to go for a smaller washer that is used for 4 mm candidated screws. That will not go through the washer. The olive part will not go through the washer. That you can use it in an osteoporotic bone. That's one advantage is there.
So there's another question on Ortho TV from a PG student. They are asking, you mentioned regarding using the olive wires in the form of a bent semicircle on the Ilizarov frame. So they are asking whether that confers stability, and if at all it does, then is it equal to or less than the normal transverse wires?
Yeah, that's what I said in the beginning of the presentation. It is easier to demonstrate on a PowerPoint than doing it on the patient. So a straight wire will go through the 1/4 of the cortex along to the medullary canal, and then you just pick it out with your hand or with the instrument to the other side of it. And now you want to bring the wires two holes anteriorly. So on one side, on the olive wire side, you fix it to the hole where you want to get the translation of the bone, tighten it up. And on the other side, you try to keep the wire in the same hole along with the wire fixation bolt and start tensioning it. During the process of tensioning, the bone will lift up. So it's very difficult to get on the table, but in fresh cases, maybe you may get it, but not in old cases because a lot of fibrosis. Once you get the wires elevated in the sagittal plane, but the bone is eccentrically placed in the rim. So you need to get a translation in the coronal plane. That means you loosen the wire friction bolt on the other side, the first side, and then try to translate coronally onto the lateral side, and then tension, fix it in the initial stage, and then tension again onto the other side so that you get good tension. It is same. Tensioning is the same for even during translation also. Unless you try to bend the bone, or disfigure or deform the wire. You should not.
We have Professor Milind Chaudhary sir here, so we'd like to have some expert comments from Milind sir about this, sir.
Hi, thank you. Thank you for inviting me. The curled wires that you spoke about is very interesting. I think that we use sometimes in internal bone transport a long time back. And I think your innovation is nice. You can use washers.
Yeah, you can put a wash.
Yeah, that's
They're all on the table innovations, sir.
Great. Recently, there was an article in JLLR from Israel, and the gentleman said that the curved K-wires are the covert villain in the Ilizarov fixator in results. So I had a really tough time accepting this article. But then there was such a lot of mathematics that he had used. And it was quite convincing that if you don't take a lot of care while actually tensioning the wires specifically, you can not only create, we know that it will create soft tissue tension and infection and skin breakdown and adherence, but he went as far as to call it the covert villain. So the wires we're using with extreme care. If there is a lot of patience to take care of the patient in the post-operative phase, then wires are great. In certain circumstances, in really osteoporotic bone, what you said, I remember the bone is so porotic that we can't even use olives. I mean, there have been very few instances where I've only put 3 or 4 plain wires. It's simply the olive is not going to stay. And just by the crisscrossing nature of the plain wires, and they get basic minimum stability as they walk. Once the patient starts walking, this is for people who haven't walked for a long time. Once they start walking, they start developing good bone, and then the wires improve their grip, and then you can add on a couple of things later. But that's, yeah, I liked your innovation.
Sir,
Dr. Cutting your voice.
Sir, am I audible, sir?
Yeah, it's disconnected.
Sir, am I
now it's better,
Yes,
sir.
please. Yes, please.
Sir, Shamshul sir, as we have, Miran sir, as we have recently gone to Russia, where we have seen their style of tensioning with the special connecting bolts, sir. What is your comment on the tensioning at the visit than the table on tables? While patient is coming for the consultation, if we feel the wire is not adequately tensioned or it is loosened or yielding strength is lost, can we tension it by that method, sir? Miran sir, can you please?
Yeah. They're a very interesting question. Huh? You've really understood the real problem. I think the secret to that is, so if you do the Russian tension again in the OPD without anesthesia later on, the small amount of deflection of soft tissues can give rise to pain. But I think the direction of the nut and the wire in the wire fixation board, because if you notice, they use all mostly eccentric. So yeah, if your nut placement and bolt placement is accurate, then the possibility of loosening of tension itself is very less. So what I would do, what I did when I was using a lot of wires, is the side on which you tension, if you place the nut in the convex side, tangential to the if the wire is tangential to the direction of the turning of the nut, and then you feel that the wire has lost its tension, then what I would do is go on the opposite side where you've just tightened it and use a wire tensioner rather than fiddling with this. Because if you undo this and then, this play of the soft tissue, and the patient may complain of pain in the post-operative phase.
So while tensioning in the OPD, you will give a releasing stabilizations, or you will proceed with just tensioning and leave them?
No, like I said,
there will be skin.
No, like I said, I would tension the opposite side. Okay, if the Russian tension, normally let's presume you have an olive or you have a plain wire. You've tightened it on one side, you've given the Russian tension on the other. If you suspect that it needs retensioning, I would first go and tension on the opposite side, see for relief of pain. If there is, then I would not bother. But then under the circumstances, you're right. If you need to release the wire, just do it. Retension. If you need to release the skin tension, yeah, you have to do this. You have to be prepared.
And one more thing is, while we are tensioning in a Russian method, we can't ensure that every wire is tensioned in the same way. If the patient is walking, we can't expect that every wire takes the same weight. As a highly tensioned wire takes more weight and it has more chances of breakage as well as the early plasticity.
Yeah.
Isn't it, sir?
Yeah, so more than 30 years ago, when I first went to Russia and I asked this question, all of us have a lot of questions about their method of tensioning. So we asked, how much tension you give in which case and all that. So the gentleman, I remember, I think Professor Shwed, there was a much older gentleman, he did this. It's like, see which way the wind is blowing,
What is that?
It's a they have an instinctive way of explaining. They have an instinctive workman's way of working. So you try your best. You try and equally tension all the wires. It's based on the angle of the you figure these things out as you go along.
Thank you, sir.
And
Sir,
Sir, any additions or other faculties?
Milind sir, many times we saw that they are not using tensionometer, but just doing with both hands with the ridges only.
Absolutely, absolutely.
So what do you suggest, sir? Which is a better way, sir?
I think it requires a little bit of expertise. If you're a little bit of expertise. So for a surgeon like you, for all the ASAMI India members, the experts who are here, you've taken the trouble to go to Russia. For all the people who are going to take the trouble to take care of the patient in the post-operative phase, I think it's definitely worth trying. If you're an occasional, Ilizarov surgeon and you do that, you're likely to create some difficulties. There's small little points, which I'm sure, Shamshul, you know very well, that, Professor R.A. Agarwal is also here. He's also, very well versed with this. And so if you follow the points, I think it really works well. But if you're not comfortable, if you're not getting this thing just right, because, you need to almost fully tighten the nut, loosen it a little bit, and then move together, and then continue in the same smooth motion to tighten the nut, etc. So you learn this. You learn these tricks. And if it's not working out for you in the post-operative phase, then you should be happy using a wire tensioner. Because I'll tell you, in 1991, there was the first time we had a conference in KM Hospital in Mumbai, and I was invited. I was back from the US only a year and a half ago. They were selling a tensioner at that time, a French tensioner, for 70,000 rupees, which was costing more than a Maruti 800. Okay. So it made a lot of sense to do Russian tensioning. The Maruti 800 was the only new car available other than the Fiat and the Ambassador. So, today's day and age, it's not a problem. You do what you're comfortable with. We are spoiled for choice. You don't have to.
Actually, the only advantage of the Russian tensioner is that it needs a very, the saving of the time is there, most probably, because it runs very fast.
I agree.
But I personally feel that you are doing the Russian tensioner, and if you are near the fracture surface, sometime it may displace the fracture.
Yes.
So I always use whenever we are away from the fracture, definitely saves our time. That is the more important is there.
Yes.
And I purchased a lot of tensioner for the Kungan. After 4-6 months, they all have become useless. So now I'm using the Pitker tensioner because it's not working.
So based on that, then I would like to share a story. 10 days after I got married in 1990, I was forced to make a trip to Milan to purchase some Ilizarov equipment like the wire tensioner. I spent 5 days in Milan. I switched 3 hotels to save money because I had very little money. And I finally found the manufacturer, who is the son of a surgeon. And I had to do this. And I got it for $700 at that time. And now these are all old things, all equipment is easily available. Everything is easily available. So, so that was a Smith and Nephew tensioner. That was brilliant. But now everybody makes good tensioner. There's no problem.
Sir, there is a basic question from a postgraduate student on Ortho TV. So he says that I have been through rotations in 3 units, and some people bend the wire 90-90-90. Some people turn it like a semicircle, and some people break it after tensioning. Which one to follow, sir?
Yeah, the best one would be keep them as a semicircle. In case you want to adjust it again, it's always better to keep them semicircle with a sort of what you call rubber or a plastic, something like that to cover the sharp end of it. But if you are very sure that you don't need to tension or do any adjustment later on, I preferably bend 90-90 so that it will not injure the other side of the limb. If you cut them There is chance, suppose he's sleeping there, he'll hit the cutted part of the wire and then it may injure the other limb, other side of the limb.
I tell you the story. Well, sometime when you remove the frame, you do not do, you can put the olive wire in the opposite side. So what you do, sir, whenever it is the olive wire, we do tension on the wire, the 90-degree bend. And otherwise, we do the semicircle. 90-degree in the olive wire, so that we should know that this is the olive wire. Otherwise, semicircle.
Manish sir, can you have some expert comments from your side, sir?
Yeah, Shamshul, actually, I was seeing patients, so I have not heard it. Maybe I'll follow it now. I just finished my clinic, so I'll be there. And Dr. Milind, good evening. I didn't wish you. Dr. Milind is there?
Hi, Manish. Hi.
Yeah, hi. Okay. I'll be, I was actually seeing patients, so just joined it.
Sir, repeat the question, sir. Vasudevan sir has also joined us. So,
I think the question had to deal with how much to bend the wires outside the bolt. I think the only practical thing is to make sure that you can straighten it thereafter and retension when the need arises. If you bend it more than 90 degrees, if you straighten it, and the thing is, the place where you bend should not be where the chuck of the tensioner grips the wire. That's what's going to make it break.
Dr. Milind,
Biomechanically, you bend the wire outside the ring anywhere, any shape. It is not going to change the biomechanics of the ring. It is your whims and fancies. If you are very confident surgeon, you are locked it well, and you are not expecting that to create trouble, you can bend it 90 degrees. And or like Agarwal sir said, you can bend in a different way for olive wire, so you can identify it. So these are all silly things, not a very major issue.
See, the basic rule is that wire, if you have to tension it, so it should not have bend. So you have to bend it at least more than 2 fingers or 3 fingers in length, and just do it in a circular fashion towards the ring. Because what happens if you have to straighten the wire, it is easy. Otherwise, if you had different 90 angles, then when you straighten the wire, it becomes very difficult. Basic point is that.
How often, Manish, you have to retension the wire?
I rarely do it. But
so that's
some
it.
people.
So that is the point. If you do it properly, the chance of retention is practically nil.
It's practically nil. And I'll tell you one thing. If you use good quality implants, like I always use Pitker or very high quality implant, you rarely require bending a wire. But if you use some, implant which is not very, good, or it has an irregular ring or holes, so wire gets, they lose their tension. So that might be required. So it is recommended that tensioning is rarely required, very, very rarely, and you should use good quality implant.
And good technique.
Good tensioning.
Sir, Ramkartik here. Hello, I'm audible, sir.
See, recently I went to Russia, and I was surprised that they don't use the tensioner at all. So I don't know how effective is that, because they do all the tensioning manually only.
When I went to Kurugan, they are selling good tensioners.
Now they don't use tensioner at all. So I was surprised.
They are selling tensioners.
Yeah.
They were selling tensioners and they using fans also.
Yes.
They're doing 2 bolts at once, sir.
So you have no idea when you are doing manually whether you are doing in a proper tension or it might come with an experience. But I still use the tensioner. Maybe in foot and hand, I might use because tension you have to put less. So I might use the manual method, or in children. But I think in a femur or tibia, I would like to use the tensioner.
Sir, question, sir. Sir, am I audible, sir?
Yeah, sir. Go ahead, sir.
Sir, Vasu sir and all, do you have any, is there any difference between the chances of tensioning the wire between the hybrid fixation and all wire frames, sir?
A fully tensioned wire is biomechanically equal to a 6 mm untensioned pin.
Sir.
That's it. You can, I use it in combinations. But I don't believe original, because when the car was invented, it was not like the car which we are using now. When the science is advancing, when the knowledge is advancing, we must also try to change. Just because the original is like that, and that I don't mind. You want to use a pin, you can use pin. No tensioning needed.
Yes, sir, that's what I'm asking. Earlier, you have used all-wear frames. During the all-wear frames, what about the chance of retensioning at the all-wear for the all-wear frame, as well as the chances of retensioning in the hybrid frames? Any differences you have encountered with this?
No, I don't think I have ever retension.
I think you are asking the question because you probably felt the need, and I think there's no need for us to be very overly dogmatic that nothing is needed ever stuff. Yeah, if you need to retension, you retention. You take a judgment call. Your rigidity is not going well. There is pain. There is instability. You take a judgment call. Yes. It happens. It happens. It's known to happen. We are not superstars to make dramatic statements like nothing is 100% is never needed. It's needed. It's needed. If it's not needed,
no.
It's not needed.
In the beginning stage, we have to do that. Then later on, you learn the tricks.
Yes, sir.
Even in case you want to retension it again, I mean, the one scientific explanation is that you take out the pin first, tension the wire, and then apply a pin in different place. Not the same hole, but different hole. That is scientifically accepted.
Sir, come again, sir. Didn't understand the point. Can you please repeat, sir?
In case you want to retension the wire, let's imagine yourself. Suppose there's a wire and a pin, or two pins and wire is there. You want to retension the wire. The explanation, I mean, scientifically, you take out the pin and then tension the wire and then reapply the pin, preferably in different holes, different places.
Sir, rationale, sir? Reason for that? A rationale for that, sir. Why to remove the pin?
Suppose your pins are inside and you try to tension it. The pins will not allow any micro translation of the bone. When you tension it, there's a micro movement that is not allowed by your pins. So take out the pins, tension it again, and reapply the pins.
Anesthesia.
So can that be done just by loosening the post?
Yeah, you can loosen the pins and then do the same
has
thing.
been tightened.
Yeah, you can do that.
Yeah.
You can do that way also.
Sure.
One question Dr. Wilfred Desa from Goa has asked: has anybody used a hexapod quick action tensioner?
Shamshul sir had it, I think.
Yeah, can you repeat the question, Akansha?
Wilfred sir from Goa has asked: has anybody used a hexapod quick action tensioner?
That it's like a, what do you say? I have not used it. Maybe I don't know. There is a kind of a Smith and Nephew tensioner, whether it is known as quick wire tensioner. Wilfred, is Wilfred there?
Yes, I can hear you.
Wilfred, you are talking about the Smith and Nephew tensioner.
No, there was this tensioner that was brought by Hexapod.
Smith and Nephew with Taylor special frame, there is a tensioner. I'm talking about that. That is Hexapod only.
Okay. Probably I'm not aware of the new tensioner by Taylor.
See, I've used that. Tensioning is same like our dynamometer, but it is easy because it is like a plier.
Yes, that is one by Integra. I've just got one. It will cost around 80,000. You can just use like a plier.
That is the Indian version.
Indian
version, but you get the tensioner, same tensioner of Smith and Nephew, which is provided by the Taylor special frame when you apply it.
Right.
Okay, what about a simple fundamental question? When you're tensioning the Russian technique, you can tend to cause a little displacement of the wire by maybe a millimeter or so from the original position. Is that kind of acceptable by the Russians?
So see, Russian accept, I had asked the same question to them, what you are asking me. They said that it works, but I have never, practically used the Russian technique. I learned it now, and I'll try and see whether my wires get, the tension, they lose tension or not. But I have told them that, the wire, they tend to displace, but say, no, it is tension, so let them get displaced, does not matter.
It kind of fundamentally defeats
Maybe
the
Dr.
entire
Agarwal, he has been using Russian technique. Maybe he can put some light. If he's there, Dr.
Are sir is not here.
Has just now left, sir. Sir, since we are little short on time, sir, can we go ahead with Ravindranath sir's case presentation, sir?
Sure.
Yeah, I have one case presentation in a middle-aged lady. Shall I share my screen?
Yes, sir, please, sir.
I think it's visible to everybody, I believe.
Yes, sir. It is, sir.
Yeah, this is a case of middle-aged lady. She has come with a grade 2 compound comminuted fractured both bones leg on the left side, which is exactly 1/4, lower 1/4 of the tibia. I always call the lower end of the lower 1/4 of tibia is known as graveyard in orthopedic. So that is radiograph, both AP as well as lateral view. But unfortunately, she also has got a worse fracture on the right side, which is more comminuted and with the extension of the tibial plafond, but mechanically well aligned. Both are compound in nature. She's about, I think, 50, 55-year-old lady. So the management protocol just I followed is I just assess the soft tissues. Since it's a compound nature, we cannot go in for a internal fixation. Then I need to mobilize the joints, neighboring joints, and then mobilize the patient as early as possible, which is on both sides. So I always believe that the skeletal stabilization heals the soft tissues much faster than keeping them in bed. So the principle that one should always follow is it is crucial to go or put in at least 3 wires when the fragment is very, very small and closer to the joint line. So that's the tibial plafond, and those are the neurovascular structures on medial side. And that is a distal ring, or you can say a reference ring. And then that's the first wire going through the syndesmosis as well as fibula. The other 2 wires are intersecting that way. And that's how we have got the fixation on both sides in the same sitting. And these 2 things are reduction rings, and the other one is a supporting ring. I always prefer to go as far as possible to maintain the working length for supporting ring to get the stability of the frame. And that is the immediate post-operative radiograph on the right side. And then on the left side, you can see the tibial plafond is well maintained horizontal to the ground, both in anterior-posterior and lateral views on both sides. And then mobilize the patient immediately, I think by 3rd day post-operative. Surprisingly, she is so comfortable to walk on the frame with a walker when she is in both sides are fixed with the frame. That's the frontal gate, gate on the frontal view and gate from behind. She is so comfortable on the 3rd post-operative day. And we lost follow-up of the patient till she came to us out of 3rd month. This is the 3rd month she came walking like that into my OPD with frames on without any support. And there is some amount of hind foot valgus, not much. And we have taken the radiograph at the end of the 3rd month. It's totally consolidated with well-maintained ankle motif. And then patient is happy with the union there. Thank you very much.
Sir, am I audible?
Yes.
Sir, Ramgat.
Yes.
Sir,
Yes, sir.
In which conditions will you
fantastic.
add the foot
Fantastic
ring for
result.
the TIBIA fracture?
Excellent.
I can't hear you. Can you repeat the question, please?
That was a wonderful presentation, sir. Karthik, sir, you are a little bit inaudible. Can you please check your signal, sir, once?
Yeah, am I audible, ma'am, now?
Yeah, we can now. Go ahead, please.
Now you are clearer. Yes, sir.
Sir, in which conditions would you would like to add a foot ring in distal tibia fractures? What is the indication? Like, what is the distal fragment size?
Suppose this patient comes, let us say, after 6 months' time, you expect some amount of disuse osteoporosis. Or when fragments are so, the combination is so high that you don't have any bone to hold the whites. In that case, we go into a solid bone that is talus or calcaneum. In that case, we need to, I extend it to foot with a foot plate. The disadvantage of foot plate is they can walk, but as they cannot walk as freely as you can see in this particular video.
Yes,
but they do work with foot frame also.
Okay.
So there's a question from Dr. Sudhir, who's an assistant professor. He's asking, how much time did you take to remove the frame in this bilateral case, sir?
Yeah, I was telling she came to me only after 3 months.
Sir.
And to our surprise, it's so consolidated. She came walking, getting into a bus, in a country bus, and then came walking to OPD. It's a real surprise to me at the end of 3 months' time. Maybe the comminution and the metaphyseal area is helping her to get the good consolidation there. Whenever I see there is a radiological union and clinically patient is stable, no complaints, then I try to, if I have some suspicion, I to dynamize the ring first, wait for about 4 weeks time, then remove it. Some people, they get disgusted with the frame. Then I remove the frame, put him on a PTB or something like that to get rid of the frame. Otherwise, I always wait for the radiological union and then only I remove the frame.
Yes, sir.
There's a question from Sudhir again, how to maintain the pin track infections.
Yes, sir.
What I follow, I don't know the experts agree with me or not. I used to use a spirit, a squeezed cotton in a spirit. Not the spirit should not come out as drops. You should squeeze them and then clean the frame thrice a day, right from the skin onto the frames, onto the rings. But I noticed the patients will not do the same. They have some sort of excess spirit or whatever it is, sanitizer that goes into the tissues along the wire. So what I find very useful is I ask them to take a bowl of water, put a cotton in that, boil the water with the cotton in, at least for 5 minutes. It should boil for 5 minutes and then cool it down. And then keep it in a safe place with a lid on that. The person who wants to clean the frame has to wash his hands like as you do for scrubbing and take out a piece of cotton and then try to clean the whole frame and then throw that to water for next day. Next day, take again one more bowl of water and then boil them. It's much easier and you will not irritate the intersection between the wire and the skin. The frame hygiene is very crucial to prevent the pin track infection.
Yes, sir. And Dr. Karthik Reddy has asked, sir, postoperatively, when the patient develops abnormal swelling like that of induration, how to address that case?
Yeah, my protocol is as long as the frame is there on the patient, is on the patient, I ask them to keep limb elevated throughout it, maybe 6 months time or whatever it is. Elevation is very crucial. It should not be dependent. And if there's some induration with erythema, think of some local infection, some sort of cellulitis. You can get it off with oral antibiotics, or if it is very severe, some IV antibiotics. And then elevation is very crucial. The frame is there on the patient, the limb has to be in elevated position.
Sir, in a few cases where we have a displaced medial malleolus, have you ever applied an oblique olive bag for the compression?
Yes, we can do that. We have done a few cases.
Right.
Where we can extend the same post distally and then pass a wire to the middle malleus. It will go somewhere in the middle of the leg, and then you can fix again with a post. That you can do, no problem.
Exactly. So that is a very important key point for the freshers that if you have displaced middle malleus fracture, we can use pulley wires for compression.
Yes.
Sir, Dr. Wilfred Disa from Goa has asked, please enlighten us on dynamization of distal tibia fracture frame, sir.
Yeah, the principle that I follow is you put weight. Suppose you have got 3 rings. Let us say the proximal ring is known as 1, the middle ring is known as 2, and the distal ring known as 3. So you need to dynamize between 2 and 3, the second ring and third ring. Suppose if you put weight, the weight goes from distal to proximal, isn't it? The weight of the body will go from distal to proximal. So we need to loosen that particular nut, which comes in the way for your what you call weight transmission. Loosen that by about 2 or 3 millimeters, and all. Like I use about 3 threaded rods only, or you can use 4 also. I mean 4 also can be. You loosen those 4 nuts and allow the weight to bear, patient to bear the weight. Then that becomes dynamization. If you are in doubt, loosen on either side of the like second and third rings. Then you are very safe. Can do that way also. And dynamization is for only about 4 to 6 weeks time, and then the fracture should consolidate by then.
One more question, sir. Suppose we have a oblique fracture, a spiral fracture in the distal tibia. Have you ever used obliques and counter obliques for compression, for interfragment compression?
Yeah, we have done that. Again, we use the same posts and then do the same thing.
Exactly.
We can do that. We have done that also.
Yes, we can use of drop wires also.
Yeah,
was the same. Right. So.
But initially, I used to do all these Ilizarov procedures with a manual drill, which is a precious item nowadays.
Right.
I used to do all these wires with manual drill. We used to have this Einar drill, this closed gear drill. It was difficult for us to pass the wires when there's the oblique fracture, but with mechanized or power drills, it's easier to do the same thing.
Akansha, there is a very good question. How to tension drop wires? Please, sir, please.
Yeah. Suppose you want to tension it, let us say. Suppose the post will take about 2-hole post. I go for 4-hole post. Okay. Then you fix it on one side, and then with all the 4-hole, you can use a busher or one more female or male post or a rancho cube. Over that, we can tension it. You get good tension, and then tighten the nut once tension is over. That way you can do tensioning over the post also. That means you have to go for a bigger post, tension it, and then you have to interface. You should get some interference with a same male post or female post or a bridge plate or a rancho cube, and then you can do it. Preferably plates. Rancho cube will not accommodate in the dynamometer.
And sir, I would like to.
We have Prasad for
ASAMI, if they would like to give insights on this question.
We have
Prasad, how to
sir, can we have some expert comments from you, sir? Yeah.
Actually, I do with Russian method of tensioning by taking it a bit away from that and then rotating the nut and bolt at the same time. But usually it should not be tensioned too much, otherwise the ring will yield and bending will occur in the ring. So that minimum tension should be given, and I'll do it with a oblong side slotted bolt and the nut, and rotating it onto the correct tension tightening side, rotating it onto the tightening side of the nut, and you will get tensioning of the wire. It should be minimum, should not be more, that it will not yield the ring, otherwise the ring will break. If we are doing in TIBIA, if it is not up to the 110, it should be up to 60 or 70 measurement.
Yes, Prasad is right. Normally, if the drop is very close to the ring, you can do little, maybe the other wires are 130, you can do about 110. As the distance increases, reduce the tension. Yeah. Because the more far away, it will warp the rings. When the ring is warping, the rods will bend. It will create undue tension. The far away from the drop, I mean, from the ring, your drop is far more. You reduce less tension.
Sir, there's a question from Dr. Wilfred Dessa again. He is asking if anyone has reported a breakage of distal tibiofibular wire after starting the patient on weight bearing.
Can you repeat again? I couldn't hear it.
Yes, sir. The question is, has anyone reported a breakage of distal tibiofibular wire post weight bearing?
I never seen it in my life. I have not seen that.
And sir, there's another question from Dr. Joel. He is asking, are there any tips on preventing hindfoot valgus in the case that you presented, sir?
Yeah, I could have gone for a foot plate, but that was not available then. A foot plate can neutralize the heel varus or valgus.
Sir, there's another question from Dr. Joel. He is asking, what is the protocol after the removal of the frame, sir, in this case?
Yeah, just remove the frame and she started walking. She went out of the theater walking. That's all, nothing.
Yeah, there is no need of brace in this case. Yeah.
There's no need to brace her also. She came in a bus with the frames on. That means the bone is united totally.
So there is a postgraduate student who is asking that after removal of frame in their institute, they usually use a PTB brace for the tibia. So is that indicated in all the cases, sir?
Not necessarily. Suppose if you find that radiologically it's united, and then you dynamize it for about 4 to 6 weeks time, I think you can straight away remove the plate, remove the frame and wire, and then mobilize the patient without anything. If you're in doubt and the patient is not comfortable with the frame and you find multiple pin track infections and it's radiologically uniting, then you can go for an external splintage in the form of PTB or a brace and then support the limb till it gets consolidated radiologically.
But usually I support after removal of the frame, I support, because doing a redo is much more difficult and much more difficult to convince the patient also. So I support it for about 6 weeks. At least we manufacture the splints actually. We manufacture the splint, custom made, and then we give it to them. We ask them to remove in the night and then use during the daytime while walking, or at least.
Yes,
if
sir,
not PTB.
Yeah, because all patients are not very intelligent. So you have to.
Yeah, true. Especially maybe Ravindranath sir's patients may be in the city.
No, I dynamize them. Dynamization is very crucial for me. I
Yes,
dynamize at least even for 8 weeks also.
I dynamize them still, but still I don't believe in them.
I don't. Okay, that's true.
I don't
That's
leave it
true.
to their hands. I leave it to. I'll keep it in my hand till they are comfortable.
Vasu sir, do you have any insights on this, sir?
I usually keep the ring little more than removing a day earlier. So if you are planning to keep a PTB for 4 weeks or 6 weeks, I will keep my frame 6 more weeks and remove it.
Everybody has got their own methods. Their own methods of keeping the patients into your hands.
Yeah.
Because I don't want to prove that my external fixation time is much less. I'm not fighting with anybody else. Prasad knows. We are not making on the numbers. We have to be safe.
Sure.
Sir, there is a question from Dr. Dilip, assistant professor from Kerala. Sir, he's asking if we try for wires distal to the fracture. In this case, that he has uploaded an X-ray, sir, and he is asking, it may become intra-articular as we need to maintain 2 centimeters proximal to the joint. How to address that, sir?
the 2 centimeters is the actually safe margin. But if you are quite intelligent and check in all directions that if it is not going through the joint, then you can apply it. You can go nearer to the joint also. You can go nearer to the joint. Taken care that you take proper precautions that it is not going through the joint. That is what is required.
The only problem is when you are using a stainless steel ring for such a very small, tiny fragment, you may not be able to see in the CR.
Yeah.
So what we can do to use here, you can either use a carbon fiber ring or do that wire first. Before putting the ring, putting the ring itself, use the difficult wire first. So suppose there's about 2 centimeter distal fragment. What I will do, I'll pass a reference wire and other 4 wires minimum first, and then fix it later. So
That is
I
the
can
classification method.
Yeah, because classical method.
Then attach the rings next.
Yeah.
The trick of the trade in this case is all these wires, whether you pass 2 wires, 3 wires, or 4 wires, they should be parallel to the tibial plafond. So the ring will be oblique. Once you rotate the limb in alignment with the dome of the talus, it becomes straight or perpendicular to the limb. It becomes very simple procedure later on.
If anybody else would like to give any insights on this, please, Manish sir, Anup Maurya sir, Ameya Bera sir, if anybody would like to say something on it.
Yes, we can see Ameya sir for the long time.
Yeah.
I have just make a small request. Everyone, try to use tensioner always. Don't use your Russian hold with a spanner and that tensioning. Reserve that only when you are in trouble. You're not able to tension it, then use it in trouble. In a troublesome situations. Generally, try to use a tensioner. It is worth spending money on that. You can even, the even company also gives that. So don't try to prove that all wire is best or Russian tension is best. And not that way. Get good stability. You must get good stability. In the mid tibia, it is very difficult to get 90-90 hold. So there is nothing wrong in putting 1 wire and 1 pin. You'll get better control on that. Non-union is
So your voice has gotten disconnected, sir.
but it will still do the job of tightening, compressing there. The compression still happens.
So we lost you in between, sir. We lost your signal in between, sir.
I'm sorry. Can you get it now?
Now we can see you, sir, also.
Oh, good.
Better now, sir. Thank you, sir, for joining.
So far, I have been hiding myself. Okay. So use the tensioner always, if possible, because in the tibial shaft and all, you may not get 90-90 wires. When in compression also, even if you put the pin, because you know orthopaedics is sealed many non-union. Doesn't mean when you use wire only it heals, and when you use pin it is not healing. That is not correct. Whatever you use it, go by appropriate principles. We are using pins, use appropriate principle for pins and appropriate methods of doing it. Finally, the thing is the result should be, you must get the result. That is the most important part.
Yes, sir, definitely. So there's another question on this X-ray that Dilip sir has uploaded from a student. So they are asking that we are taught to stabilize at least 1 column and then go ahead with fixation of Ilizarov frame. In this particular X-ray that Dilip sir has uploaded, can we pass a rush nail, get lateral column stability, and then pass 3 wires across the distal fragment of the tibia, sir?
Can you upload that image?
Sir, it is there on the chat box. It's there on the chat box, sir.
Akansha, you can just download and share the screen.
Yes, sir. I'm just.
Anybody can open the chat box and then see that X-ray. It is there in chat box.
Yes, sir. It's there on the chat box, sir.
Yeah.
Open the chart and then you will see that.
Here it's a supramalleolar fracture. Agreed?
Yeah.
Get the tibia and then, there is a syndesmotic rupture also. You can see the syndesmos is also not good. Try to get the distal fragment stabilized along with the fibula. You don't have to recombine. When you put only with a wire on the fibula, see, this is the best case where you get both tibia and fibula fracture. You consider one segment distally, one segment proximally. By putting a rush pin there, I don't think you will get any extra benefit.
Okay, sir.
And it is very difficult to get the length of the fibula when there is a lot of comminution.
No. The issue is, where do you want to get the length of the fibula? See, that is for your conventional plating. When you maintain the length of the fibula in this case, you are creating gap in the tibia. So, when in an Ilizarov treatment, the length of the fibula doesn't make. When you're plating, yes. Here you equally shorten. You can equally shorten the tibia and fibula. And you can equally lengthen the tibia and fibula. So for Ilizarov surgeons, the relationship of the ankle motis, medial malleolus and lateral malleolus is more important than anything superior to that.
Sir, hello, good evening, Akansha.
Good evening, sir. You're audible, sir, and visible as well. Please go ahead, sir.
Okay. I have learned a lot. In the index case being discussed, there is tibial plafond involvement is there. If you see carefully the lateral view, so that fragment should be reduced. And if we distract through the talus or calcaneum pin, then the fragments will fall in better position, and thereafter do the fixation. That's my only thing, I think. Bhaskar, sir?
I think we have lost Vasudevan. Manish Prasad, sir, do you have any insights or your take on this one, sir, on this case?
I actually agree with Dera sir. Whatever he's saying, that is exactly what is in my mind. So use a calcaneal pin, distract the fracture, get it aligned, and it will just require 2 minutes to have a ring distally. And I would also like to say that this is a perfect case where we might require to add a foot plate for an added stability over there.
Sir, if I may ask, after the frame removal and consolidation, what should be our protocol, sir? Should we give the patient a below knee walking cast or a PTB, or how should we proceed, sir, in such a case?
Yes, a protective brace or a cast will go a long way. I always do that. That is how I have learned also. And none of my patients have had a bad result or a poor result if we have done that.
Just I would like to make one point. In these metaphyseal fractures, PTB cast is not really needed that much like it's needed in the diaphyseal fractures. That's my practice. In diaphyseal fractures, if I am not sure about it and after dynamization, it's a 1 month or 6 weeks. Yes, those who cannot be depended upon, and if then we can do. But otherwise, in metaphyseal region, it's usually not needed. But rather, my practice is not to give it the PTB cast. Okay. Thank you, Akansha, for excellent organization of the things.
Thank you, sir.
And all the contributors also. And Professor.
If anybody else has any questions, please ask.
It's a really excellent discussion on the basic Ilizarov technique. I really appreciate the professors as well as the students. And thank you, Akansha. Thank you.
Thank you so much for coming, sir. Sir is our Telangana Ortho Surgeons Association president. Thank you so much for taking time out, everybody. One last question from a postgraduate student, sir. It seems in his medical college, after doing distal tibia fractures, they apply a below knee slab on the frame. A pre-made below knee slab, which may have been used, I believe, for some other patient. Is that recommended in case we are not adding any kind of a foot frame, sir?
Never, ever. That should be applied, okay?
I should appreciate the person who can apply a below knee slab on a Revisor frame. I really appreciate him.
It is.
The mechanism, the technique is to apply a slab on a frame.
Sir, sorry to say that's the common practice because Ilizarov principles are not taught in the properly in the postgraduate, very few, except very few medical colleges, and therefore they neither stick to any standard method. That's the problem. Okay.
I don't agree with you, sir. No, you made a very drastic comment on medical colleges. No, I am
there.
No, I don't agree with your comment at all.
Except
No.
Whatever my knowledge in this part, sir.
You are sending a wrong signal to the youngsters here.
No, sir.
No.
They have just texted, sir, saying that only in those cases where we could not apply a foot arch, do we use a below knee slab, which was probably used for some other patient, a pre-made one. That's what he just texted, sir, on Ortho TV. Okay, sir. Sir, Dr. Al-Sharif from Jordan sends his regards. So it was a pleasure to join this webinar. All the best. And thank you so much, everybody, for coming in. It was a very academically enriching experience. And thank you so much, sir. Shamshul, sir, would you like to?
Thank you, Dr. Akash, for the chance given to me.
Thank you so much,
and
sir.
I tried my best to go down to the basics in my presentation.
Thank you so much.
Thank you very much.
Thank you so much.
Thank you, Akansha. It was nice organization. Good talk. Thank you very much. I could not join earlier. I came a little late.
Thank you so much for coming, sir. Thank you, Manish, sir. Thank you, Prasad, sir. Thank you, everybody. Shamshul, do you have any exiting remarks? I think we don't have Shamshul, sir, online, but
he left, I think. Yes, some other work, and he left just now.
Yes, sir. So everybody sending their deepest regards. Thank you so much, everybody, for coming in.
Okay, ma'am. Thank you, ma'am.
Thank you, everybody. Good night, sir. Good night, everybody. Bye.
Good night.